you know, of course we know we need our doctor's order, we need consent. Your patient may or may not be awake. A lot of times these are put in the OR, but they're definitely done at the bedside as well. You put your gloves on. First thing you're gonna do is your Allen's test to make sure that that's good. So it's good. And then we're gonna clean the site. So that needs to be done so that it can dry while you're setting up, because you can't dry it with a towel, you can't do all of this. This is where we're gonna talk about the importance of the sterile technique, because the #1 risk of an art line is infection, and it's very real. So per CDC guidelines, minimum sterile technique requirement is caps and gloves. They don't mandate gowns, although most places do use them. How many people have seen art lines put in? Were people full sterile? Yeah, most of them are. It just depends, yeah. Yeah, it depends on where you're at. Yeah, and if it's an emergency, you're gonna do the best you can. But in a perfect world, as sterile as you can get. So when you clean, we're not gonna open these. These are just our little props, but they will come with 3 cotton swabs or Q-tips inside. And so you open it. The important thing when you're swabbing a site is you never go back in. So just like when we do ABGs and we go out, you do the same thing here. So you're gonna take your swab and you're gonna start at the very center of the area where you're gonna stick, and then you're gonna go out for 10 seconds, and then you're gonna throw that one away, and then you're gonna start where you left off, not going back in, and you're gonna go out more for 10 seconds, then you're gonna get rid of that one, and then you're gonna go out at the end for your last 10 seconds, okay? And then we're gonna let that dry. We're not doing any hocus pocus over it. So if you can, the patients are not normally gonna be awake for this. It's just not a pleasant procedure. But if they're kind of drowsy, and you never remember what somebody's gonna feel, so you can just tell them, I'm gonna let that dry. Well, I'm gonna get my things ready here. I will be sure to let you know when we're ready to start the procedure, so they don't think that you're doing anything crazy with them. So when you're doing this for the first time, of course your pressure bag is gonna be in a package, and so is your saline. I think most of us know you have to pull the top out, spike this, and then when we're gonna put it inside the bag, make sure you're not using a 1,000 cc pouch with a 500 ml pressure bag. It will pop the heck out of it. So there are 2 different sizes. Make sure they match up. So you'll insert this into here. And then ideally, this one's broken, but this little flap here, you'll take this and put it through it so it holds the bag up, and then hang it on the pole. Some of your bags have a little blue hook, so you could put it on there as well. This one's broken, so I'm gonna start it at the table so that when I pressurize it, I'll be able to hang it without it sliding out, because otherwise it's just gonna slide out. So next thing we're gonna do is pressurize our bag. So you have your stopcock here. So for this particular one, the arrow is pointing to the way it's off. So right now it's off to the bulb. So can I pressurize the bag? No. What about if it's off, off to the bag? Can I pressurize the bag? Nope, and you'll hear it coming out. You'll get to know this sound. So if I want to pressurize the bag, I need it off to the atmosphere port so that the air will go through. Now you can hear the difference. So get your muscles out for this part. You're gonna pump it up to 300, which is gonna be the green. So look at the stopcocks. Make sure you guys are all passing it around so you can see which way it needs to go. I understand some of you don't have your saline yet, but you gotta know how to work these, you guys. So we're gonna keep going until we get to 300, which is gonna be in the green. It's gonna feel like you're gonna really need to eat your Wheaties.
Oh my God, it's high. It's tight. Yeah, it's so tight.
Yeah, it is. It needs to be that way. The hardest part is getting to 150. Once you do that, it goes pretty quick. So 250. As soon as you see the green, you can stop. So there's the green. Yeah. It's because you guys don't have a bag in it. So you guys, it's going to look like this. Really, we want it pressurized. That's the only way it's going to work. And then here's the green little bit there. I'll show you. And then once it's there, you guys want to take the stopcock and turn it off to the bag so we don't lose any air.
Turn it off.
To let the air out, put the stopcock to the bulb.
So this is let the air in. This is
and then
keep the air in, and this is let the air out.
Okay, so let the air out.
So now we're hanging.
Wait, what? Why are we letting it out?
Oh, okay, okay.
All right, guys. We'll have plenty of time to practice. Pay attention, please. So now what we want to do is run our line through, get any air bubbles out. So to do this, you have to make sure this is open, because we'll close it when we're ready but when we're after this part. So this needs to be open. All of your stopcocks need to be pointed to the port so that the fluid can flow through. I told you. And then to get it to prime your line or flush it, you can either push these two together or pull the little pigtail. And then it should come out. The lines will work, and if you've done it properly, they will work, which is why you all have cups. So see now I flushed the line. It's all coming out. There should be no air bubbles. And I'm going to turn this off to the bag right now so that nothing's, no. Yeah, the last little, so now right now nothing's coming out, okay? So this part here is the transducer. Come on, guys, we'll play more later. This part here is the transducer. The purpose of the transducer is to convert the pressure to a waveform reading on the monitor. So there's a little port here. So this would hook to the monitor, the port from the monitor. And once it's inside the patient and working, you would get your waveform. And it looks like a pulse oximetry waveform. It should be nice and have that nice little dichrotic notch in it. You guys have seen them on the monitors. But for right now, we're just gonna do this. So now that's ready. So now I can get my supplies ready. The most important thing that everyone has to remember is you can't get sterile until everything's ready. Once you get sterile, you should be ready to stick the patient. So if you don't have things ready to stick the patient, you should not be getting sterile. That's the biggest mistake people make, besides for contaminating. So I have my sterile gown, my sterile gloves. I would have my cap on already. I should have my cap and my mask and gloves on. But right now I'm just gonna open supplies, so I don't need to have gloves on. Because right now I'm gonna wash my hands again and I'm gonna get everything ready. So make sure your hair is all stuck up inside this beauty. You don't wanna have anything left hanging out. No, we don't wanna. There we go. So this is gonna be our sterile tray. And when I put things on here, you guys, I want it to be reverse order because I want what I'm going to use first on top, okay? So I need my non-fenestrated drape for this. So when you open sterile, as soon as you see the blue there, you cannot go past that blue with your fingers. So when I open, I go like this. I put these fingers underneath like that, and then I pull back. Now, I see people do this all kind of crazy ways. You can't just do this and fling it everywhere. Sometimes people want to do it like this and they think they're going to dump it. That's not how we do sterile. The idea is you're going to open it here and then flip it onto the tray. We're not opening over the tray, that contaminates. But for the first one, this is actually gonna be our sterile field. So for this one, I can pick it up and you'll see here that one side has white edges and the other side doesn't. So I'm picking it up at the very end of the white edges because you'll see 1 inch around is not sterile. And you can kind of see there's a little marker. And you're gonna do this with the blue away from you, gently shaking to get it. And then go away. Never go towards, and that way, that's gonna contaminate. This way, and then you can see I'm naturally pulling away. And then you'll see there's this little marker here. 1 inch around is not sterile, which is why I can do this way. So now this is my sterile field, and I'm gonna open my supplies onto it. So last thing I would need is Tegaderm. So that goes on the bottom. So I'm gonna slowly open and dump and back away. So then my ring is next. So I'm gonna open, dump, and back away. See how I'm not opening over the field. It's also not a football. That's my other favorite to see. Ooh. It's gonna flip right off the other side. That's not what we're doing. And then I'm gonna need my art line kit, which this one has a lot of extra things in it that we don't need. But for now purposes, I'm just gonna open it and dump it. And then lastly, my fenestrated drape. This one we're not opening or touching, we're putting it on the field. So I open, see how I open it this, hold this end firm, dump it. Don't do that. Technically that doesn't count. So put it right there, because it can't be on that part. So now I have my supplies ready, so now I can get sterile. So, and if you need to move this, you move it with your foot. You don't turn your back to your sterile field, because you never know what somebody might do to it. Not realizing. So we will keep sterile gowns and our gloves. We're not gonna reuse these 100 times. We're gonna just reuse them until we do our checkoffs. So, and then there's a way you can fold them. A couple people will get good at it if you don't already know how. There's a YouTube video that kind of shows you how to fold it up. So there's this little flap here. This flap goes away. This goes away. This goes away. And then this goes away. I could technically have done this part ahead of time. So it's ready for me now. My gloves, I need to have out of the package because you're gonna have your gown on when you put your gloves on. So what I do for my gloves is, there's this little thing right here, right here. So I'll show you here and then I'm gonna move them back. So I will take them like this, open them, make myself a little fold at the bottom so that they're ready to go. And then I'll put them here. So if we were in the OR, we would use this, but we're not. So we've already cleaned our hands. Now when I get my gown, see this little curve here? That's our little smiley face. That's how you want it to face you. And I'm just gonna get rid of this, get it out of my way. Because technically I'm all ready to go. So when I put this on, I'm gonna put my hands in the little pockets here and then make sure you're not gonna touch anything. And then it's gonna open and fold. And then someone is gonna help. So Nate, if you wanna come help me. What's gonna happen, put your arms in and then don't go crazy. You're gonna grab that little Velcro. Yep, right there. And then Velcro the other side. Go ahead. Obviously it's way too big. That's all right. And then there's ties in the inside and the back that you're gonna tie. We're not gonna do anything in the front. Your hands cannot come out. So now we're gonna have our Charlie the crab hands. Wait, you didn't tie me in the back.
Oh.
Yeah, crab hands. See the inside ties?
Oh, that's the outside ties.
Did you see the inside ties?
Yeah. Okay.
Yeah. So here we go. See what he's tying the inside. Okay. So now I'm gonna put my gloves on. Remember, your fingers can't come out, that's contaminated. So the way I do my gloves is I do thumb to thumb. So I picked it up, here's my left thumb, and this is gonna go towards this. And then I'm gonna take these little edges and I'm gonna shove my hand in them like that. And you're really not supposed to do a lot with them until you get the other one on, because you gotta get your fingers out of this little white part to be able to do anything. So just leave it like that for now. Get the other one, thumb to thumb, which is basically flipping it upside down. Take the insides parts. And as you guys are doing this, I'll come around and help you. Shove your hand in. Now we can adjust everything. It's really weird doing it, especially when you don't do it a lot. So you have to get your fingers out of the white part, and once you do that, you can pull the gown down and get your fingers adjusted correctly. You gotta be careful if your fingers are not out of the white part, because it will tear the gown. And then you have to start over again. And then get this all covered good. My hands are all sticky, of course. Technically, you wouldn't have any watches or jewelry on for this. Okay, good enough. Okay, so now I'm ready. So now I can get my tray back. So now, of course, we can tell the patient we're ready to get started. So I'm gonna take my fenestrated drape now. Get this out of the way. Now I can touch it and put it over my site with the hole going where I'm gonna stick. Now,
The site is typically radial, but it could be brachial also, right?
I don't really see them at brachial.
Okay, so
No,
radial.
radial or femoral.
Or femoral.
Yeah, we don't usually see them brachial.
Okay.
Now I'm gonna take, so in the kits, we have a needle and a catheter and a guide wire, and I'll show you how it will be after the, so you'll see both. So let's just show you both ways. So if you have a needle and your catheter separate, you're gonna stick your needle in first. Got a little cap on, and take the cap off. Okay, the cap doesn't want to come off. There we go. Bevel up. Now, different from an art line, this is more like a 30-degree angle because we're trying to go in the artery, not just get blood. So I'm gonna put that in, and then I'm gonna put my guide wire in, because there's a little hole in there.
So if we do get it into the artery, will there be like an indication? Will it?
Not here, no, not right now. So we're just practicing for
But
technique.
generally there will.
Yes, absolutely, it would start bleeding like crazy.
Okay.
So I put my guide wire in, I take my needle out and at least set it in the cap. Remember, we're not gonna actually recap it with our hands, but we need it to be capped. Then I'm gonna take my catheter, put it over the wire. It's called the Seldinger technique, like this. Feed the wire through. It'll come out the other end. Feed it down. Feed the catheter into the arm. And for our arms, you don't need to feed it all the way in for our purposes, just get it in there. Then pull the wire out. Then attach your line. Make sure you get the last bit, because we just put air in there now, so I wanna get the last bit of last bit of air out. So you could just do it right there and hook it up. Then we usually flush the line one more time. Then you're gonna zero it. When we zero the transducer, we're taking into account for atmospheric pressure. So what you have to do is when this is hooked up, You're gonna take the cap off here if it has the cap on. Just like that. Take the cap off and then turn it off to the patient. This is gonna account for the atmospheric pressure in the air. Hit 0 on the monitor, and now it's gonna zero it out, so it won't add that into the pressure for the patient. It's very important to get the proper pressure. So now we've zeroed it out. We can put this back like this, put the cap back on, and now you should get an accurate reading. When it's running and open, these ports are gonna be pointed to the stopcocks are gonna be pointed off to the port so it could have an open line. The transducer has to be at the level of the heart or you will not get an accurate reading. If it's too high, so if the port is higher than the heart, the pressure will read lower, so they're inverse. If the port is lower than the heart, then they'll read higher, okay? So I'll show you how to draw from there in a minute. I wanna show you the other way. So once we use a kit, we're gonna switch to this catheter. It's pink, it's a 20 gauge. And these are short. Most of the Artline catheters are long like this, so they stay in nice and good. But so once we've used that needle and catheter, then the next time, and you could use these too, you could see them come like this, so it's important to know both ways. So this needle, the catheter's already attached to it. So when I put this in, I'm gonna put the needle in with the catheter in it and then pull the needle out. And then it's technically already in and ready to go. So we're gonna put the needle in, pull that out, and now it's technically ready to go to hook up. But you have to know how to do the guide wire technique, so we'll be practicing that too. So when I have you practice that, you'll put this one in, put the guide wire in, take this little pink one out, and put the long one over the wire to show that you know how to do that, which I'll come around and show you guys. Where's my cup? Okay, so to draw, there's 2 different ways that you'll have to draw an ABG. Most places are using what we call a vamp now, and that's what this is. So a vamp, so this would be hooked to the patient and the arm, and then this would be hooked to the transducer. So a vamp is like a syringe, but it's a little storage port right within the line, and so that we're not using extra syringes and extra contamination and things like that. So when I have a vamp in, you'll see these arrows. That means blood can get through. If I don't want it to, then I'm gonna turn it like that. So when I'm ready to draw, this is open. You'll take these 2 little guys here and just take this and pull it up, and you'll see fluid come in here, which would be your blood. So that's your waste blood. So now I got my waste blood. I'm gonna turn this off because I don't want anything coming from there. And this is where I'm gonna actually draw my ABG from. So I'm gonna take alcohol, clean it off. There's a little port cover, that's for ABG draw, that just pops right onto there. You'll draw your blood off of there and then clean it off again. And then come back here, open this up, and then you'll push the blood back in to the patient and then flush, yes, and then flush again. Super easy. The old-fashioned way to do it is this guy right here. This is in the patient's arm. You're ready to draw. You keep your port off. You're gonna put a syringe here. You're basically gonna need 2 syringes. You're gonna draw your waste blood. So once my syringe is on, now I'm not gonna open my port till my syringe is on. So I'm ready to draw, my syringe is on, I've cleaned it off. I'm gonna close it to the bag, draw my blood so it's coming from the patient. Draw off my waste blood. Before I take it off, close the port, take my waste blood off, clean it again, put my ABG syringe on there, open it, draw my ABG, close it, take the ABG syringe off. Then depending on where you're at, you will either flush the blood back in and then flush it, or you'll just flush it. Some facilities have you put it back in, some don't. Just facility dependent. As far as troubleshooting goes, there's only a couple things. That waveform can become dampened, and when we say dampened, it's just like half of what it should be. So instead of that nice tall dichrotic notch, just like a pulse ox waveform, it would only be half of what it should be. We see that when we get clots or air bubbles in. So then we would just need to clear that. Infection, of course, if you get an infection, you're gonna have to take it out. The line has gone bad. First thing we always try to do is flush the line. If the line doesn't flush, try to reposition it a little bit. Maybe it got jiggled up against the wall of the artery. But typically if it doesn't flush, it's gone bad. In a perfect world, we try not to keep them in more than 3 to 4 days. That doesn't mean it won't happen to be in longer. It very well can. But there might be even a possibility that you have to take one out and put a new one in. So once we're completely done, the art line would be in here. We're gonna tear the fenestrated drape off, take it out. Let's just say our little line is in. Then we would take our chlorhexidine ring. This has a little slit in it, but do not split it around the line, because if we need to change this ring and it's all slit around the line, then that's an easier chance for it to come out. So all we're doing is covering it. So if this is in my patient's arm, I'm just literally putting it on top. And blue towards the sky. Blue to sky. That's how you know blue is up, just like the sky. And then I would put my Tegaderm over that. The end. And that's how you do it.